Good morning, everyone, and welcome to the Institute for Health Policy Studies special seminar. Thank you very much for being with us in person or online this morning. It is my pleasure to introduce our speaker, Jody Platt. Professor Platt is Associate Professor of Learning Health Sciences at the University of Michigan, and she was trained in medical sociology and health policy at Michigan. And her research focuses on issues at the intersection of informatics and ethics. And that's an intersection I don't think a lot of us spend time on. We tend to think of informatics over there in the tech world, and ethics is over in philosophy. And so I'm really intrigued to hear how Professor Platt is bringing these two disciplines together. She's primarily interested in understanding what makes data driven health trusted and the pathways for earning, achieving, and sustaining trust across stakeholders. And I think we all know trust is such an important part. And while we tend to think of it maybe at the individual level between health professionals and their patients, it's also important to think about the trust we have or don't have in institutions and how to achieve and sustain that trust. So, without further ado, Professor Platt will present on building trustworthy systems from principles to practice in advanced healthcare analytics. For those of you in the room, when we get to the question and answer period, we'll be using the handheld mic. And for those of you who are joining us online, please put your questions in the question and answer forum, and we'll read them aloud to Professor Platt. So,
Okay, good morning. Thank you for being here. Um, I am going to talk about building trustworthy systems from principles to practice in advanced healthcare analytics. And one of the reasons we're talking about issues of trust, ethics, and informatics at the moment is that we are sort of experiencing a huge expansion of health information technologies in our everyday lives, not only in sort of the clinical space, but also in our telephones, in our uh, um, again in our daily lives. The EHR is here. It took a while to get here, but we have it. We may not like it, but we have health. We have electronic health records. We increasingly have the ability to share and exchange information across EHR systems. We're increasingly able to integrate data from multiple sources, and it's $1 billion industry. So whether we like it or not, we're spending a lot of money on developing this space. And we also see a huge amount of variation, which isn't surprising, in our capability of using these information technologies. So, small local hospitals are going to have lower capacity at the moment than advanced health IT spaces, and that has again sort of ethical implications for equity, for access, and for a whole host of issues. And that's really sort of the context for most of my work. This expansion of health information technologies is doing two things to sort of our world. One is that it's straining our policy frameworks, and it's also straining our ethical frameworks. It's straining our policy frameworks because we're now in a place where we no longer have to sort of state upfront why we're collecting information, how we're going to use it, and to what end. When I was, not that long ago, we used to say, I need data because I'm a researcher and I have a research question. I would like to sort of obtain your informed consent for a study. And there were rules that we had to follow around sort of why I was going to collect information from you. At the moment, we can now collect data again in our phones, in our weather systems, in our electronic health records, and then we can decide how we would like to use it. So, if we're going to be using it for uses beyond clinical care, what are the sort of expectations of the patients for that health information use? And that's really what's driving a lot of my work. So, what are the appropriate policies now that we have this sort of new ability to use health information? Some would argue even an obligation to use information to improve health. What are the appropriate guardrails and guidelines? Where do we need to innovate, and where do existing structures work, maybe? The expansion of health information technologies is also straining our ethical frameworks. So, um, we were just talking about sort of the philosophers and the ethical people sort of for a long time were sort of able to sort of think about the clinical care moment as sort of their focus of ethical attention, and developers and informaticists had a different didn't necessarily need to think about the same kind of ethical questions that our bioethicists did. And at the moment, as we're beginning to bring these two spaces together, we have different ethical frameworks and different value propositions for each of the people that are involved in expanding health information technologies. Each of these sort of sets of professionals and interests and stakeholders have different values and ethical frames. They also have different access and power in the decision making processes that happen at the level of health systems. And they have different scopes of work. So, what a clinician is expected to do in their daily life is very different from what a developer is expected to do in their daily life. So ultimately, again, we're at a place where we can maybe sort of change some of our ethical paradigms are up for debate. Our guiding principles are up for debate, and how can we ultimately improve health systems and begin to be more inclusive in our decision making and governance of health IT? At the moment, there's a whole host of both data principles that are floating around, but there's also emerging guidelines from all kinds of places on how we can use AI to reduce algorithmic bias and to improve health equity. The Office of Science and Technology Policy just earlier this month put out a bill of rights for an AI Bill of Rights. Um, there's work being done by coalitions, the Coalition for Health AI. It's funded by the Gordon Betty Moore Foundation to develop these guidelines and guardrails. How do we actually implement the tools that we now have in our toolkit, and how do we implement them in ways not just to sort of maintain the status quo, but to actually improve on the status quo? My own guidelines and guideposts very much come from one of my previous mentors who passed away early in 2020, Toby Citrin, who was very much an advocate for community involvement and community participation in genomics and public health. And he very often would quote the Institute of Medicine's Future of Public Health, and it's not in there the way he said it. But basically, what he said was that health policy is the determination, and policy development is the determination of a course of action that blends all of that technical expertise and the professional knowledge with community values. And so it's incumbent on us to sort of begin to understand what are those community values and how can we blend those with what we know as experts in the field. The other, I'd say, motivator for most of this work stems from work that I did with Toby on the expansion of newborn screening blood spots for research. So this is again, data being collected for purposes of public health, and then the realization that this data could be valuable for other things, in this case, research. They had biospecimens and data on children that could be used for research. And we conducted a series of community meetings and heard things over and over, like that people were surprised. And with that surprise came sort of an impact, a challenge to the trustworthiness of our institutions. So at a community meeting in Petoskey, what other lab specimens are being taken without the knowledge of the person being tested? This will end as a trust issue. And then also issues of race and racism. Can I truly trust you? African American people are always the last to know. I want involvement and information. So this is basically the background for, again, my work, which is sort of, again, trying to connect the policy, the sort of decision making, the values of communities and stakeholders, and looking at issues that arise in informatics, and in particular, those issues that emerge from our data and information infrastructure, and then our sort of emerging markets for healthcare analytics. So I'm going to focus most of the presentation on the first sort of data research that we've done on the data question, and then talk a little bit about the work that's just starting to get ramped up around health analytics and how we can be better at communicating what we're doing in that space with the public and patients. So again, the policy problem that we're really trying to examine here is whether we're creating systems that are deserving of the trust of people and populations, and how can we better align policy with public expectations and values so we can maintain that trust. I'm going to talk through sort of some data and research that we've done to answer three questions related to this. The first, and all have to do with basically notification around data sharing, which again, it depends on how there's not a clear answer in sort of what we should be doing um, with respect to notification. So the first is, would the public like to be notified? Just the quick answer is yes, but I'll show you some data to support that. Would the public how would the public like to be notified? So what are those sort of communication points and junctures in terms of engaging the public? And then finally, just as a sort of a question of nuance, does it matter what kind of health information we're talking about, or is it just all health information? So, with respect to the first question, would the public like to be notified? We conducted a national survey. In 2019 using the NORC Amerispeak panel, which is a nationally representative probability based sample of the US public. We talked to about or collected information from a little over 2,000 people and asked a series of 12 questions. This was a pretty basic sort of study and analysis, but we wanted to know how true are the following statements on a scale from 1 to 4. There were 12 statements asking, I would like to be notified about university researchers, quality analysts, or commercial companies using my identified or de identified health information and biospecimens. And we're trying to understand whether people care about the user of the data, whether how much they care, or if they care whether it's identified or de identified, and whether they care whether it's health information and biospecimens. Again, in part because our policies for each of these different combinations is slightly different. So in general, people would like to be notified. So everyone sort of fell above the mean, regardless of which combination we were talking about. There was a stronger preference for notification around identified versus de-identified data, again, regardless of user. And that's important because quality improvement can use identified data without informed consent or notification. The notification is light. There's no difference in the public's minds between quality improvement and research. And again, that's huge because the policy paradigms for those two spaces is really different. And also, interestingly, there was no difference in this particular aspect of the study between health information and biospecimens. Again, in policy debates, people like to separate those two things. But again, in the public's mind, it seems to be sort of, you have my stuff, I'd like to know about it. So we then conducted a series of qualitative studies to understand how people would like to be notified. So it's clear they want to be notified. How would they like to be notified? And we conducted here a series of public deliberations. And I know you guys have had some real leadership in the area of public deliberation. But the idea here is that you can bring people together to try to sort of make decisions in a sort of informed and educated way. And you really sort of allow the time and space for discussion to happen. Our process that we used was a little bit shorter than some that are conducted, but we would bring people together for about a day, sometimes spread over 2 days, and we'd have pre-test, large group discussion with sort of information providing, Q&A, small groups discussion, and then we'd repeat the process. The other sort of key aspect of this research is the sort of final step of communicating our research results, not only to the participants, but to people who can make the change. And in this particular case, we engaged CMIOs in particular, chief medical information officers at Michigan Medicine, to sort of hear and listen and respond. And in some cases, actually sort of do something about what it was they were hearing from their patients. So this deliberation had to do with notification around data sharing. We used as our sort of use case precision oncology and breast cancer in particular. And we went through those two scenarios. So the first scenario was trying to understand how and why health information is shared in the context of care and population health. So really basic. Florence sort of goes from her primary care provider to the detection of a breast tumor. The tumor is genomically sequenced. She receives treatment and follow-up care. And we also tell sort of the back end story that sort of at each of those sort of moments, data is collected, it's shared among providers, it's shared with commercial companies, it's shared with hospital registries and national surveillance data. In the second scenario, we focused more on the role of the commercial company and how health information may be shared with them and what are the issues related to that. And we asked them, because it was sort of a short version, we asked them to prioritize a set of preferences that we gave them. So we asked them in the first context to prioritize whether they would like to see just signs in clinics, whether they would like to have sort of texts or emails, sort of active notification of data sharing, whether it was just important to have the information available in their patient portal. And of course, there's always the option in policy just to do what we've always done. Um, in the second scenario, we retained some of those options to again sort of just notify people through the patient portal or sort of more active engagement through text and email. But here we also explored the options of being able to opt out of sort of long-term data sharing out sort of after the clinical experience. We also proposed that patients could be compensated for providing a valuable resource. And then again, no change to current policy. So it can be a little bit fun right now to try to decide sort of what you think is the first choice in each of these scenarios, but you don't have to wait too long. I'm going to tell you. Um, so for scenario A, the notion of clinical care, the portal was the people's first choice, the status quo was the last choice, and then there's some level of variation between the other two options. Again, and I'll go through some of the rationales and thinking behind sort of how people arrived at their preferences, but the notion being that the portal would be at least accessible to the people that were engaged in care, and that the others might not go far enough or might go too far in terms of signs or texts. In scenario B, again, the portal was our top choice here, and no change was our last choice. Compensation was not particularly popular, but the second option of opting out was sort of the second most preferred. And I'll talk a little bit more about opting out in a bit because it ends up being sort of a recurring theme and something that's really important to people. And it's not entirely clear how we're going to do it. So it's worthy of future research. But what we heard in these deliberations was that people want policies that are convenient or at least don't increase burden on the patient and that are ultimately accessible to folks. So, and again, sort of a recognition, we ask people not only for themselves what their personal preferences, but what do you think the policy should be for an institution? So again, uh, not everyone is getting information or has accessibility to that information. It needs to be a point where it can reach everyone, regardless of how they're able to access it. I'd prefer a phone call, but since it's the digital age, texting would be the next best thing because it's easier. I can grab my phone, read a text, and keep moving. For me, I use the portal quite a bit. So again, people are different. For the opting out, people could see both the benefits and the costs of being able to allow opting out, and they really sort of held on to the notion that there's some level of control of their health information because it's some part of them and who they are. I don't want people to opt out. I think that it will stunt progress of medicine, and I want to take advantage because we all benefit from that. My gut tells me that everybody should have the right to opt out. My brain tells me that if we have that option, it's going to limit benefits too much to everyone. Um, and others saying, I chose opt out because you should always be able to make your own decisions on what happens and what doesn't happen with your healthcare information. And sort of somebody sort of invoking the my body, my choice. And this was pre Dodd. But ultimately, change is desirable. I just feel like something should change. It's lawyer language. Even as someone who should understand it, I don't. So, as sort of a final sort of step in this research sort of initiative, it was an R01 funded by NCI. We are also sort of looking at what does it matter what type of information is shared. So, in these scenarios, we were talking about genetic information and EHR data, and we sort of treated it all sort of equally. Um, so, in the sort of the third set of data collection, if you will, with set of projects. We conducted an additional survey, again using the NORC panel, but this time conducting a conjoint analysis, a discrete choice analysis embedded in the survey, where we were able to sort of provide a series of A/B choices where people chose policy A or policy B and changing just a few different attributes between each of those, and then asking a bunch of times, and then we can sort of, anyway, you guys, blah blah blah. Okay, So this is just an example of this. And then the next slide, you'll be able to see the different levels. But we were looking at sort of, again, how patients would be learning about data and information sharing, whether that's genetic or EHR. We've cued into the importance of identified versus de-identified to see if that was sort of the driving decision maker. We also included a couple of attributes related to governance. So is it okay for the hospital to just make all the decisions, or do you, again, sort of feel like opting out is going to be an important attribute? We also looked at how long biospecimens might be kept, and the reasons we might be using the information. This is, again, we had about 750 in one group, 790 in the second group. And here what we saw was, again, a very strong preference for identified, sharing de-identified versus identified in terms of being comfortable and having preferences for, using de-identified over identified. Preferences with being able to opt out of data sharing, again, becomes there's a desirability for that kind of some level of control. And here we saw that there was a greater preference for genetic versus EHR data. So that maybe for some types of data, the sort of ability to control that level of granularity may be higher or lower depending on what kind of data we're talking about. But again, this is early. And then the last two attributes didn't really seem to shift people's minds too much. They didn't seem to care how long it was being kept. And it wasn't the purposes, these were all decent purposes for people to support data sharing. So that's developing new products, developing new treatments, or evaluating the accuracy of diagnostic tests. So when we look at all of this work on sort of data sharing and the ethical issues around data sharing in the context of precision oncology, we begin to see that moving beyond the status quo is sort of exigent and what we need to be sort of thinking about and having lots of sort of discussions around. We know that people definitely want to know, and we know that people are going to be different. If you have to start somewhere, the portal is probably the place to start. But again, that's not going to be the answer for everyone. And there'll still be people who feel like they weren't told and they didn't know. Opting out is clearly a sort of a persistent preference among people, but what does that really mean for people to be in control of their data? I think is the higher level question that is important to, again, sort of engage the people that can do things. The public doesn't seem necessarily ready for the health system to be the sole decision maker around how their health information is being used and shared. And so we need to have conversations about what type of governance is appropriate, and how do we include folks in that decision making. And then, clearly there's a much stronger sort of comfort with the de-identified over identified data. And it's a little sloppy in the real world, right? That line between de-identified and identified. And so to the extent we're using de-identified data that's later identifiability, that's sort of a potential sort of major breach of trust in the weight. So that's sort of the work we're doing in the data space. And now we're sort of beginning to launch another sort of set of activities looking at healthcare analytics. So this is AI, machine learning, smart technologies, predictive models. I'll get to this. I'll repeat it when I have to say it again. But we're doing a lot of work right now to understand what word is the right word to be using, because each one of those is slightly different, and yet we also need to be understandable. So here we're again sort of engaging with the questions around how our digital world will indeed mirror the challenges, biases, and inequity in our three-dimensional world, and and how do we sort of ensure that we're not also replicating the biases and inequity. So here we have a grant that's still in its first year to get to sort of do a similar kind of methodology that I just described, where we can do a survey, we can sort of engage in qualitative methods, including public deliberation, and then do larger surveys, sort of follow-up surveys afterwards. Here, the goal is to figure out sort of what does it mean to have a product information label for AI in healthcare. There's some work here it's being done on I think they're calling it digital package inserts. But the idea is that we need to sort of figure out how we notify people about the use of AI. It's one of the pillars of that blueprint for AI that's been part of the AI Bill of Rights. And what is the information that we need to have accessible to folks who are interested? So again, we're sort of working on this survey development phase, looking at sort of how do we pick the right terms that people are going to understand. What are the appropriate corollaries and metaphors that people already know, so we can sort of meet them where they are and use that as a point of departure. In our sort of preliminary focus groups, we heard a lot about, oh, this is just like the stock market, or it's like your Google Maps, or it's like targeted ads, and being able to cue into some of those metaphors to sort of see how they relate to people's opinions about health and healthcare. And then finally, also identifying examples that make sense, right? Um, there are there are many. Um, we're currently sort of developing our sort of library of images and stories about healthcare, how AI is being used in healthcare. Um, and beginning to sort of mock up our prototypes for what the label will look like. So this is based on a series of 65 interviews with various stakeholders. These were more expert interviews than sort of public and patient interviews, but trying to identify again sort of what are the key attributes that people are going to want to know to be able to make an evaluation of the tools that are being used in the context of care. And I think this also speaks to that desire for control and knowledge and awareness about what's happening to them. Um, we're also exploring sort of different governance frameworks. The FDA has a lot to say about this in terms of, sort of making sure that governance is a key attribute of AI when we're talking about things that are high risk. Um, and institutions looking to sort of understand sort of what's the level of involvement they would like to have in managing the AI tools that are being implemented at any given moment. So again, we're already sort of at very nascent stages, but there's a sense that we still need to be moving forward. Um, and recently received some additional funding on top of the project that I just described on healthcare AI to sort of really focus on the issue of measurement. Right, we have very complex notions of trust, of equity, of accountability, of even sort of our core bioethical principles of autonomy and beneficence and non-maleficence. How do we measure that and assess from the public how they've like where they are on those different sort of sets of values and ethical principles? Um, and so in this project, we'll basically sort of do the work of trying to understand how to measure that. We'll use structural equation modeling to understand, to sort of identify the latent factors and sort of identify how we can measure something that's essentially unobservable, and then relate that to expected benefit and comfort with the use of AI, which we know is sort of related to the acceptability and ultimately sort of trustworthiness of an institution and its practices. Um, we're also working on developing tools and resources that institutions can use, drawing from the data science world where they do a lot with maturity models, which is a very structured approach to developing software. But it also provides a nice roadmap of showing, I'm at level 1 now, and I'm going to go to level 2, level 3, and level 4 for a series of processes and practices. So a lot of people who were working EHR models, uh, this notion became really popular because it was like you can't just adopt an EHR and suddenly it works. What you can do is have an EHR and you can enter in a few different things, and that's sort of your level 1. At the very highest level, you can do very sort of complex data integration and precision health. And so then the idea that you can map out these progressions can be a useful tool both internally to sort of spark dialogues and understand where you are and where you want to go. But if you there's some people there's another camp in the maturity model space that says, okay, well, let's try to standardize this and we can then compare across institutions. Um, my own person just start at home, but And then sort of in the sort of final sort of set of activities, beginning to understand how to focus on building trust and how do we sort of look at health systems that are maybe becoming too big to care, and try to sort of integrate greater levels of humanity, um, and uh, um, and ultimately trusting the public and the patients that we serve, with sort of the complexity of the issues that we're talking about. I think in general, uh, in every sort of patient engagement, public engagement activity, uh, we've heard very sort of smart. They can deal with it. We can. They're not. They're. It's this is easy. What's hard is finding the solution space. But the solution space sort of comes from collaboration across sort of multiple fields. None of this work is done in isolation. And again, I sort of started with the idea that this is an opportunity to build better systems. Again, sort of marrying the notion of policy as the confluence of values and professional knowledge, ethics, and then sort of your substantive area of expertise. That's it. Thank you.
And sorry, I couldn't be here in person until midway through, but I was listening
Okay.
on Zoom. Thanks so much for an interesting talk. I mean, I have questions about a variety of aspects just because I found a lot of it interesting, but just starting with one, uh, in looking forward, your focus on building trust and this idea of can health institutions become too big to care? I
Mhm.
wonder, is that something that emerged in, some of the qualitative research that you did? What does that kind of look like on the ground? And what might the future of, like, how might we address that topic in particular, that challenge?
Yeah. So I think, I mean, it's definitely come through in the sort of qualitative work over time. It's also come through in some of the quantitative things where we find sort of altruism to be an attribute of all kinds of people, regardless of sort of how they end up making decisions about whether they choose to take a vaccine or not, or sort of follow the rules that we say that they should be following. So I think that's sort of where that idea came from in our work, um, and and I think the other piece of it is just in observing the ways in which our institutions, we may very well have really good clinical care experiences, but then our billing department is running after people for not paying what they need to pay. And so you end up sort of undermining a good experience, and people then won't walk in the door in the first place. So that's where that came from.
I'm happy to ask another question. Um, and I've, with Dan Doan, who's faculty
Yeah.
here, I've been able to work a little bit on analyzing public deliberation data
Mhm.
around human tissue biobanking. So
Yeah,
like,
right.
I'm reflecting on
Mhm.
some of that. Um, I mean, maybe everyone else got this, but I thought it would be also really interesting to, if you had a chance to unpack a little bit that AI label. I know it's just a mock-up, but I think it might be interesting to learn a little bit more about what you felt, what your team felt might be useful to the public, and how you came to decide what was going to be on there, and how you see it potentially evolving as you work with stakeholders.
Mhm. Yeah, so we can look at it real quick. There it is. It was just coincidence that the sort of design team picked on UCSF. Do I need to stay there? Okay, for the mic. Um, I think it's okay. Okay. Everybody's accusing me of too loud, but yeah. So it was the study here was again, we were using hepatitis C as our use case, where was a tool that was developed to identify potential outcomes of hepatitis C and sort of people that would most benefit from a very high cost drug. The cost has now come down a bit, but the notion being that you could have an AI tool that predicts better outcomes and ultimately sort of allocate scarce resources. So that was the use case. We interviewed again, sort of, this was mostly professional stakeholders and mostly sort of thinking they were very not, they weren't thinking so much about patient but this is, so I think this is more of what a clinician might want to know rather than a patient. So that's one sort of place where this will probably develop, although, you know, they're all people, so they so I would say sort of A through E were all things that came very clear in the course of our the fact that, you know, and there's sort of things that you might expect, sort of validity, how long has it been used, does it work, how has it been adopted, what patient population is being used to develop the model, will it work for me and my group. The inequity consideration came up afterwards. It often came from speaking with sociologists or policy people or ethicists, and not necessarily the developers or the clinicians who weren't even necessarily, their primary concern was not equity. It's not part of their job description. It's not that they don't care, it's just not that what they think that they need to do. And so we ended up adding the sort of inequity based on the other stakeholders. So that helps. Yeah.
All right, I have two questions, but we'll see if anybody shows up on Zoom between them. So I'm kind of pondering, so this is not a well-formed question.
Okay.
The intersection between some of these decision analytic approaches and then the discrete choice experiment that you did, which I'm like, ooh, cool, discrete choice experiments. In that, you know, I think some of the AI approaches in general clinical guidelines often have the risk of not having appropriate points for taking into account people's preferences. And I think there's also an intersection in that of, you know, thinking about the disparities, which I find hilarious for Hep C because like the population with Hep C is already marginalized in general. So like how could you miss that? But okay. Um, but you know, you also have disparities and differences in how you know kind of what people want and those preferences. And so, you know, I'm kind of just pondering or wondering where you see there might be opportunities for intersecting and leveraging better, whether it's AI or it's just decision support systems or so on, that do a better job of ascertaining what the individual might be. And I think oncology is probably going to be one of the most obvious cases for that because there are any number of advanced cancers like esophageal where your average life expectancy is longer if you take the palliative care and your quality of life is better if you take the palliative care. Now, if you go with the treatment and you're the 5% that survive the treatment and get a, you know, actually end up in remission, it's like you won the lottery. But some people might take the bird in hand of the palliative care, as it were, not like there's not uncertainty there. So, yeah, I'm just curious how you see those intersections developing and what are some of the underlying policy and ethical things that we need to be attentive to?
Yeah, I mean, was there a question? We had a request to Okay, there you go. It's a great question. And you should tell me if I'm sort of not understanding the question. What, but
I mean, my question is very vague, so it's
but
cool.
there's so you know, clearly what we have in AI and ML is a tool that can be used for any, you know, it can be used for good things, it can be used for bad things, it can be used just to, you know, it can be used for anything in between. It may end up being sort of net neutral. Um, I'd say the people who are often advocating for the use of AI and ML sort of say, okay, well, if we can help arrive at a set of sort of options and decision and sort of choices for patients to be making, then that can actually support a discussion that needs to happen between a patient and their doctor. And so, again, it may not sort of indicate which of those preferences the patients will ultimately go for, whether it's sort of the quality of life and sort of longer thing, or the other, but it may help sort of guide a discussion that is ultimately more enriching for all of the people involved. So I think that's a place for it. I think the other place is, sort of in this next sort of set of uh, measurement issues, right? So at the moment, trust is a made. The American Board of Internal Medicine and Academy Health and a number of professional organizations are out there trying to say, okay, and quality. I think it's HCAPS. They're like, okay, how can we actually include trust measurement as a part of what we're trying to understand in quality? And I think trust is sort of the first set of issues that we're going to want to be able to measure and evaluate over time. But we also need to sort of keep checking on these health equity things and inclusion. And I think that's where policy can come in, right? To say we actually need to be checking because we're not very good at that. Yeah.
Oh,
Uh, Two questions from Hal left. I'll ask the first and second following. Do you have any evidence on whether people are more comfortable with their data being shared if there were or if there was real patient involvement in the process, i.e., not just the hospital making decisions?
So if somebody asks for permission, will people say yes? Is that the question, you think?
I believe so.
Okay. There is some data. Well, there's two ways to answer that. So the sort of study that it sort of came into my mind is that, again, sort of going back to the BioTrust case where they wanted to use newborn screening blood spots for research, they had sort of a policy for grandfathering in a whole bunch of blood spots. But then they also said, okay, well, now we know we're going to use it for research, so we would like to implement an informed consent process. And that is work that's been going on for decades. It's still going on in terms of what's the best way of obtaining informed consent. And again, now when people are asked, I want to say it's about 80% say yes and 20% say no. I don't know sort of what's in that 20%, but yeah, if people are asked, most people will say yes, but not everyone. In terms of whether or not having like a real high quality conversation with people about how their health information is used, my guess is again, people will say yes. Patients who are sort of being enrolled in clinical trials and have a high trust relationship with their provider will say yes to participating in clinical trials. In general, when you ask people who do they trust to use their health information or who do they want to hear about sort of health information sharing from, they'll say their providers as sort of a trusted entity. But again, I don't know that providers want that extra job to do. So um, it would be nice if we could help in that regard, I think.
Second question from Hal left. Where do things stand on the ability to say hospitals, hospitals to limit the ability of commercial entities to reuse the data they have without asking for permission to use the data they may have been given to explore a different question?
So I think the question is, to what extent can we actually ask commercial companies not to use health information? Reuse. Yeah. Once we've sort of, yeah. Um, it's, uh, well, again, I'm going to sort of give a two-part answer. So I think at the institutional level, institutions sort of negotiate the terms of data sharing and data movement, right, from their institution to the next. And Every institution has sort of a different set of philosophies around that. It's also true, again, from an equity perspective, that a hospital that doesn't have the capacity to do that kind of testing on their own and needs to rely on a commercial company can basically negotiate lower prices in exchange for that long-term data use from commercial companies. And so it's like, it, it's what do you do? Do you say okay, or do you try anyway? That's sort of the ethical conundrum there. Um, yeah, I think that's the main answer. The other sort of more snarky answer has to do with the way in which we sort of implement accountability around sort of, and I that's just me being cynical and not actually knowledgeable.
Okay, so thanks, Jody. My question has to do with your finding about the preference for patient portals. If you could talk about why, what was behind that. And one of my reasons for asking is that we know there are pretty significant digital divide, disparities in terms of who has, a computer at home, who has access to a smartphone, and who, regardless of income level, knows how to actually make the patient portal work.
Yeah.
It said the spouse who has to help the other spouse navigate.
Yeah, and me answering, I can't. I don't know. I never mind. Too much information. Um, Yeah, so I think that the feeling there was, and particularly again for I think the cancer use case, that if you have cancer, you're probably you're engaging with the patient portal. Um, there was a recognition and sort of again a dialogue around that issue of access and accessibility and sort of the you know, patient portals aren't that great anyway. People have multiple patient portals. But the notion that the information is out there somewhere and that they could probably find it if they needed it, that would be a logical place for people to go. Um, yeah, but it was broadly recognized that that wasn't like the end of the story. It was like, that might be where to start, but don't rely on.
All right. So my second question is around the acceptability from the perspective of the clinician and separating out the acceptability from as a clinical expert, I believe that this hepatitis C model was well developed and blah, 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 versus as a clinician, this AI threatens my expertise and my pocketbook. And this comes to mind because it was like 25, 30 years ago.
Mhm.
Um, there was a product developed called PapNet that was using the same kinds of techniques that are used to screen chip making components, which are highly precise,
Mhm.
to screen cervical pap smears.
Mhm.
And of which there are many, I mean, fewer with HPV testing, but many, many,
Mhm.
many of those screened a
Mhm.
year, done by a pathologist. There are recommendations about how many they should screen an hour to maintain quality, blah, blah, blah. That probably doesn't always happen.
Yeah.
But the adoption of that technology basically got completely blocked because the people who are going to have the control over making the decision about the technology also have a financial investment in not replacing themselves. And now that said, they also could have assessed it and said, this isn't as good as we can do. What we need to do is blah 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 to make to make that,
Mhm.
like. And I'm curious how one from a policy standpoint forces the issue because in that particular case, over time, I think it has, people are still trying to develop that technology, and there are a few competitors now,
Yeah.
none of which are doing great.
Mhm.
But the technology's gotten better and better, and I would bet if you really did a head to head, it is objectively better than what is happening in any hand screening of pap smears that may still be done.
Mhm.
But right, so how does that policy get overcome? Who decides? How do you make it happen? Right? And the
No, it's
clinician
a really
trust,
good
right?
question.
Where do you tease out where the clinician trust is well founded versus self-interest?
Yeah, no, it's a great question. I'm laughing just because I don't. I mean, that's the question. Like that's the $1 million question. If I knew that, then we would all be okay. Yeah, I'll tell you in a year or two. But I think there's certainly fields like radiology where you sort of go head to head between the physician and the imager, the machine, and the machine is better at certain things. I think what it really ultimately comes down to is, or it may come down to, is asking some physicians to change their role, right? So they'll have a different sort of set of responsibilities for what it is that they do in their daily work. Again, advocates for AI and ML will often say, this is going to be great. It's going to give you more time. You won't have to spend all day looking at images of chest x-rays, or you won't have to spend all day looking at the results of pap smears. You can do other things. And Again, from a policy perspective, I think if you could actually give back that valuable time to clinicians, they might feel better about adopting the technologies. I don't know how you do that, but that may be a place to start. Or yeah, figure out what the trade-offs are.
Two questions from Zoom, one from Naomi Bardock. A question about the AI project. To get
Mhm.
stakeholder perspective on AI, how much do you develop work about the AI means to people versus asking people about specific AI projects?
Right. So at the moment, we're mostly looking at the AI, like sort of the meaning of AI, but it's going to have to get from this to that sort of specific project moment. The way we've proposed to do that is to draw from the the FDA framework for risk assessment of AI tools. So there's sort of purely sort of low risk, they're not diagnosing patients kind of tools, to sort of high risk, high stakes applications. Most of what we will be focusing on is in the middle zone. We're sort of assuming the FDA will take care of things that are going to be really dangerous and high stakes, and the low stakes stuff is just way too big, right? It's the Fitbits and the Apple Watches and that, like, there's too many. So we're trying to focus on that middle zone of things that, again, may be perceived as, again, depending on sort of your perspective, may be high risk, and may sort of begin to sort of do a little bit more than just providing straight up advice.
A question from Sarah Ackerman. Jody, thanks for the fascinating talk. What were your thoughts about how to begin moving a health system towards robust and uh, partic- participatory
Participatory.
participatory data governance in the context in which data users slash researchers may be satisfied with the status quo, minimal oversight?
Yeah, I think so. My initial thoughts around that are twofold. One is that we need to probably start collecting data on sort of engagement that makes sense to people. There's research that shows that sort of diversity in decision making leads to better outcomes, right? And so if we can remind people of that, even though it's going to be harder to make decisions in your day-to-day practice, ultimately there may be some sort of arguments for a payoff, essentially, by having that greater participatory governance model. But is it Naomi who asked the question? Sarah,
Sarah
thank you.
Ackerman.
Is absolutely right that it's going to be hard. It's and asking people to give up power is not. You can ask, but but asking them, like, actually expecting them to move from their place of power is really is it's that's what it's going to take.
Follow-up question from Naomi Bardock. To clarify, how do you get a shared mental mode of AI when you talk to people about it? If you say AI, does it mean the same as to you as it does to the person you're talking to?
Yeah, so we're actually asking that very question. It's like, what to you, what does AI mean? And so they're going to tell us, then they tell us. And if they don't know, we sort of ask, we sort of push them on sort of saying, well, have you heard it? Have you heard it? Have you ever heard it being used in the world? And if you have, in what context, right? And then people tell us about robots or phones or, whatever. And at the moment, again, we sort of need to um, keep processing the data. And we're not quite done collecting it, but at the moment, I'd say sort of we're asking about four terms: AI, machine learning, predictive models, and smart technologies. And at the moment, it's smart technologies that sort of makes the most sense to people, which isn't necessarily the way that informatics people are thinking about it, but in some ways is quite representative of what it is that we're actually doing, right? We're taking AI and we're putting it in a thing, a a technology, and we're using it. And so that seems to be the main, uh, the term that resonates the best with the public at the moment. When we then sort of do some comparative testing and surveys where we change the term, there doesn't seem to be a huge difference between many of the terms. Predictive model seems to be the scariest of the four. Um, but yeah, it's hard.
I wonder if you could just talk to us a little bit about your process in doing the deliberation in democracy, and particularly um, how you've gone about uh, ensuring that you have groups that are representative of, particularly think of the public across the socioeconomic, racial, ethnic, other demographic spectrums.
Mhm. Yeah, so what we've done is we've partnered with community organizations that are, I'd say, involved and have been in community-based participatory research for quite some time at Michigan. And so we sort of develop a partnership and a relationship with community leaders in those organizations, and we ask them to find people to participate. And so that's really how we do it. Michigan is a very segregated state, so our